of you giving me the opportunity to share experience of EHI integrations with eSushruth on behalf of CDEC Noida. Here, this is a presentation where I'm going to share my experience, our experience with EHI standards, starting from EHI standard 2016 up to the file that is recommended by NDHB. So just moving towards, I'm just going to the next slide. This is all about eSushruth, a glimpse of eSushruth. eSushruth is a complete hospital management information system. It is a compromise of all the required module that is used by a hospital, starting from front desk modules including registration, emergency, ADT, appointment, etc. Core clinical modules, OPD, IPD, investigation, service area, operation theater, diet kitchen, etc. And also along with all this, we have support modules also for CSSD, laundry, duty roster, and all others also. We have back office modules as well for finance, PIS, HR, and etc. Along with that, we have dashboards and information desk to provide the information and dashboards as per the requirement of users and hospitals. We have a separate user management module that keep track of all authorization and authentication features and authentication requirement of HMIS solution. We have web portals, mobile apps, and all these hospital specific as well as user specific solutions also. We, as a eSushruth has a various versions of implementations. We have a number of interfaces, that is through mobile apps. We have interfaces, we interfaced with a number of medical devices also, HL7 based medical devices and other generic medical devices as well. We have interfaced with all medical with a number of medical devices also. As per the implementation experience, we have a various diversified implementation solutions available. We have implemented standby hospitals to the state level and also a bunch of hospitals. We have a multiple experience of HMI's implementation. Now going towards our EHR standards experience. Prior to that, to EHR standards 2016 release, we have already been worked with ICD-10 and Stromer City also. After EHR standard 2016, we have focused all the 35 standard release in these standard guidelines. And after implementation of this, we have also grown through a pilot test run by STQC under the EHR standard compliance certification project. And we have also recommended 8 standards as 100% compliance and 10 standards as partially compliant and other standards which is being somehow being implemented a little bit. Now, right now, the current status, if we see as per the EHS standard 2016, I'm going through the step-by-step categorization under the EHS standard 2016 standards. First of all, identifiers and demographics. We are compliant with NBDS, UIDA, local identifier, and government-based identifiers. We have implemented all this. Medical terminology and coding systems that has been recommended by EHS standard 2016 as well as NDHB. First, that is Stromer City, LOINC, ICD-10. We have incorporated all these standards as per the integration points where these are required. We have also integrated ICD-O and ICD-10 for codification of diseases and ICF for disability and functional status of patient. Along with that, the standards for scan documents and images, we have integrated. We are following JPEG and PDF A2. For waveforms and imaging, we are using DICOM for storing purpose. Along with that, for the various formats of discharge, prescription, death certificates, we are following MCI guidelines and PCI guidelines as per the standard says to us. We have also incorporated specifications, and following this specification is mentioned in various ISO standard, that is 1441 27799, and also the integration and encryption techniques as per the recommendations. The overall architecture, which is says by the 18308 standard, we are partially compliant to that. 10781 and 13940 for concepts and support of continuity care. 226 not this standard is for privilege management access control. We are almost compliant to this standard. We are capturing all the access and management, authentication and authorization specification as per mentioned by this ISO standard. Going to the audit trails and identification demographics, we are partially compliant to these ISO standards. And these all the standard that I'm saying is being also approved by the pertaining authorities during the audit trail. Coming to the data exchange standard, interoperability standards that is being mentioned in EHS standard 2016. These three standards we are already incorporated till 2019. HL, we are using HL7 messages for event and message exchange. We are using DICOM for exchanging image waveform. We have also integrated a part of CCD within eSushruth. I will explain all these integration workflow later in the presentation. These are the standards that we are working. We have started working before FIRE 13606 and 13940, which we started working on before FIRE came into picture. When NDHB recommended FIRE, FIRE fulfills all obstacles and also required. That is a standard. Standard format for what data should be shared. It will be clear in later integrations also. Just I am going now deep in the workflows we have used to integrate the major standards. First, going to Snowmed City. Snowmed City is terminology main and basic terminology standard. For implementing Snowmed City, we have first find out all the integration points where the Snowmed City must be integrated, because along with Snowmed City we have Link, we had ICD-10, we have at ICD-O and ICF as well. So we find out all the points, and after the integration points find out, we elaborate, we define the ways how to integrate Snowmed City so as to not bothering the end user and also keeping our old data within the standard format. For example, where we have the already set up for old local terminology. For example, for chronic diseases and severity and priority, all these local, you can say the local value sets and core system we have already been defined within the system. For these local terminologies, we used the mapping criteria. Means we within the master, within the use of backend mapping, we map each and every clinical term of our local terminology with a Snowmed City. Along with that, where it is necessary, where it could be possible, we provide the direct searches from the Snowmed City within the various integration points. For example, for reason of visit, for disorders, body structures, procedures, where here at those points we provide the direct search from the Snowmed City databases and enter the data. Sometimes we also for few integration points we have also defined our own local reference sets of Snowmed City. Allergies and Snowmed City, allergies and chronic disease are two entry points where we defined our own reference sets using the by fetching all the terminologies from the Snowmed City hierarchy, all the descendants of a parent, and then creating our own local ref set and integrating on that point within an each issue for allergies and chronic disease. Along with that, all these points we have provided direct entries for diseases in DAC form also, and disease forms, etc. But as per our experience with the doctors and doctors and clinicians, they were already being familiar with ICD-10 before Snowmed City. We have tried to aware them through training sessions of SNOMED City, arranging by own and arranging through NRCS as well. Even after that, there is a lot of group of clinicians that want to be used as ICD-10 only. On that purpose, we have provided interfaces in which we have give the leverages to the end user and also configurable to enter the disease through ICD-10 or SNOMED City. If the SNOMED City is a user entered the data in SNOMED City, we have also used the complex mapping from SNOMED City to ICD-10 conversion. This is all we have done through SNOMED and ICD-10. For HL7 messages, we have integrated successfully. For HL7 message, we have not implement HL7 within the system. We have exchanged information in the form of HL7 messages with HL7 based medical devices practical. We have implemented it, we are using it. It is just not for POC. We are using 3 messages, ADT A04 for patient registration, investigation order, and investigation trace results. These 3 messages are being used. Rest of the are being POC, but these are being implemented using the HL7 messages. And these 3 messages are following almost the same integration workflow that is being depicted through this workflow diagram. What we have done through HL7 messages, we have just identified the triggering point. For ADT A04, triggering point is patient registration. For OML 021, the triggering point is investigation advice and investigation raising. For triggering point of ORU R01, the investigation task result approval is the triggering point. These are some processes which in our EHSUIT application. I'm just giving the first section. First HMI's application is showing the triggering point for the particular message. After that triggering point, we have just created a HL7 message at the background, validate it through HL7 engine, and store in a table, intermediate table. We have a registry system within HMIS. We have registered the devices and external entities that want these messages to be shared. So our scheduler in background is run, and these messages being shared with all these registered entities, maybe the medical device or external user. And after that, we receive the acknowledge and keep all these information within our database. And this is the overall flow how we have done integration with HL7 messages. Next, I would like to focus on CCD. For HL7 messages we have very restricted use. We have very few areas, actual areas for implementation. But with the leverage of CCD, we found a standard that could share all the clinical data that HMI solution being capturing. So when we see CCD, we first started with sharing data in the form of XML document as per the CCD structure. We started sharing with allergies, medication, problem list, procedures, and results. We successfully mapped and converted all these data in XML format and shared. But rest of the, since we found some difficulties of mapping all this data because we have a leverage of data, and sometimes CCD stuck us in the format, and we succeed. But even after that, we succeeded in 5 these clinical sections conversion of CCD document. For use case of CCD, what we have done, we just provided CCD document to end user whenever to provide directly patient whenever they require to have the CCD document downloaded for their personal use in the case of referral or transfer. What we have done, we have captured all the data, all the clinical information, allergies, complaint, investigation within EHSUIT application at various points of interaction. After that, when the patient get referred or patient get discharged or patient being transferred, all these 3 triggering points, we generate a CCD document and validate it through validate and upload the CCD document to our centralized server. And this CCD document is available for doctors only to the pertaining doctor and for the patients. The patient now, patient on giving the consent can download these CCD document, have it when they are being transferred to the transferred, referred, or discharged. This is just a little bit of visualization when we have worked in EHS standard 2016. We have just structured all these module and databases, and all these data being compiled in a compliant format, being provided to all the EHR and other centralized servers. This is just a visualization of that at that time. Now, when this visualization is, we are facing issue while working with 13606, because even after that, there is no standard. You can say that along with that, before that eobjects, we have still no standard API or format in which a particular piece of clinical information could be shared. And I just want to move on. After coming of NDHB, I'm just focusing on content and interoperability standards. The lower four standard, section of standard, along with coding systems, terminology, diagnostic images, still images, document, and audio video. All these standards are being compliant in ESOSHRUT. ESOSHRUT is compliant to all these standards, but along with that, even after that, we are not capable of interoperable. So after recommendation of FHIR, we have started working with FHIR in a couple of months before, after being recommended by NDHB. So I just move on to FHIR. I'm skipping this slide because we have already known much about FHIR, what is FHIR, and NDHB has recommended the FHIR. Next slide is just a glimpse why the FHIR is important. I just want to know why FHIR is so essential of R, because we have been struggling from a last of many years for interoperability. So FHIR is a standard which provides a freedom of technologies. It is it provides XML, JSON, and also RDF. So in case of we can move in any of the technology with a conversion of that only. It provides each resources for 143 resources in 13 modules, and these are all modules are being able to be useful or at various points or in our HMIS. So when we are sharing the data with any of the entity, the meaning of that particular data will be intactable, because this is being supported by an international standard, which is a FHIR. So again, we have started working in FHIR, but starting working with FHIR, we have also faced a number of challenges. First of all, what will be the architecture? We have started the architecture, reading after the microservices architecture base. We have just prepared with our legacy system. The bottom line is showed our legacy system. ESOSHRUT web application UI and HMIS database is the part of our legacy system. What we have done with FHIR, we have prepared our intermediate APIs, which is called HMI APIs. HMIS APIs is interacting with ESOSHRUT database, and which fetched required data from the HMIS database, which would be required for FHIR resources, and these data will be fed to the HMIS FHIR APIs, which we have developed over the HAPI APIs. We have a setup, because our application is J2EE based application. We use HAPI, and we set up JPA FHIR server using HAPI. We keep this FHIR database as EHR server. We developed a number of APIs based on the 8 essential sets being recommended by NDHB. NDHB has recommended 8 essential sets of resources, in which we have a number of resources that should be shared, that our HMIs should be capable of at least share those resources. We started working with those resources first, and we provided APIs based on those resources. So this is the basic architecture that we have followed, and these HMIs APIs are secure and authenticated, and we expose these HMI's FHIR APIs to external world, our mobile apps, and we have also done a POC with NIC with this with patient and organization resources. So now rest, this is I would like to discuss is what challenges we have faced while working with FHIR, and the resolutions that we have adopted. First of all, the first challenge is how to set up a FHIR server. How to set up a FHIR and EHR server with the HL7 FHIR 4.0 version. For that, we have found Happy. We use Happy version 4 and set up a JPA server and FHIR API. Overall, the FHIR, this is the basic CRUD operations and searching operations being provided by this JPA FHIR server. We are happy with that, and also with the use of Happy APIs. Now, next, what I have discussed earlier also, we faced how to codify the terminologies, MDDS terminologies as well as local terminologies. So same thing for the, we have mapped, and whatever data is available in health MDDS directory structures, we have mapped all these terminologies in as per MDDS and shared. And for local terminologies, what we have done, we have just provided the descriptions along with that. So till now, we have for terminologies we have used for wherever there is a provider, where there is available of international terminologies such as Roman City or HL7 code systems, we provide the URI, and rest of the cases we provide descriptions along with the patient resource and FHI resources. Next of the day, how to next, the most important thing when we are exposing our API to the external world. So what should be the identifier? Again, the same thing that we all are struggling with the national level registries for beneficiaries, doctors, and health providers as well. And most important things, the provider and hospitals separately, because as CDEC we are provider. We can say that we are the organization, we are the provider, and as a hospital whose data is pertaining to is a hospital, is a health care entity. So the registry should be separate, and for the purpose of when we have started sharing with patient and hospital information with NIC, we use NIN code of hospital. Luckily, we have a NIN code for all our hospital implemented within eSushruth. We provide NIN code for identifier for hospital, and we use a unique identifier within the hospital that we are used in our eSushruth application. For example, in eSushruth, we use CR number as identifier for patient, and as the part of NIC, they use their UHID as patient identifier for uniquely identify the patient. On the basis of these two codes, we share our patient and our hospital information within and to the NIC, in between the NIC and CDEC. Next problem was what should be the format, what should be the unique format for sharing this information, because sometimes it is a patient resource, sometimes it's an organization, episode of care, encounter, allergy, tolerance, condition, etc. So what should be the unique format should be shared. So for that purpose, we have just learned from our JPA server, whenever we have done a search or something, they return us a bundle resource. In that format, we have shared, we fix a standard that whatever data we need to provide, we will share in the form of a bundle. So in case of when we are sharing the patient hospital information, we return with a bundle of organization resource. When there is a ask of patient demographic information, we return a bundle of patient resource and organization resource. When there is a requirement, there is an API that returns the visit information of a patient, then we return a patient resource and organization resource and a collection of episode of care and encounter resource. because within the bundle there is a linkage is available, and through the linkage the specific resource can be fetched to the bundle. Right now we are sharing, we are interoperable, we are sharing the patient demographic information through this format only. Secure communication for communicating communicating to a pertaining entity, and keeping in mind the authorization authentication, we register the user. For example, right now we have registered NIC within our application, and provide each client, it means the each client or each communicating authority a client ID and a bearer authentication token. In right now we have provided a fixed bearer token. In future we will provide the session based and request based variable bearer authentication token as well. Last obstacle, various technical obstacle we have also been faced while setting the file server, and while continuously calling multiple web services, multiple operations on file server. We face various issues. We face memory out of memory issues. We have faced socket out of we have faced forbidden errors, etc. And we have also faced some problems in verification validations also of objects before before sharing. So for all these purposes, we used we post our queries in Zulip file implementer group, and some most of the cases we got the answer and we implement accordingly. So after overcoming all these challenges and resolutions being adopted, we have been able to communicate. Right now the status, we are able to communicate the patient resource for sharing the patient demographic information with NIC. What we have done while working with NS from CDEC to NIC, we call the NIC call the CDEC's API, passing the NIN code and patient identifier and the bearer token. On the basis of this client ID and bearer token, we generate a sorry, it is just a little bit changed. This is a we generate a NIC we generate a bundle, and we bundle containing the file patient resource and organization resource and share with the NIC. In the same way NIC is doing, and we are able to get the piece of information in the same format, and we are able to map the data, whatever data they are collecting, whatever data we are collecting. But when we are sharing through FHIR, the same piece of information can be understandable through this unique file object. This is whole what we have done with FHIR and our experience, but along with definitely our all these problems with the eobjects being released by Access Health and by you, and although when the registries will be open, most of the problems or ours will be solved. Thank you. Any questions?
Before anybody jumps in, I just wanted to appreciate sort of work done. Enormous amount of work done. Appreciate it. Just one clarification I wanted to ask you. So your database is completely MDDS compliant, right? All the code directories are in it, right?
Actually, for demographic, it is 100% compliance. For health MDDS, it is partially compliant. I would not say it is 100%, but most of these, most of the MDDS fields we are using, you can say that it is a 98%, 80 to 90%.
Oh, fantastic! Because then you can use this open source jar files that have been, I mean, developed by the community very effortlessly, because you don't need a translator layer 98% of the time.
Okay, great.
Yeah.
Thank you so much, Pragya. Now I will request Anurag from Let's Talk to present his learning.
Yeah, hi. First of all, I would like to thank Pragya for such a detailed presentation. For a person and for a company like us, it was a huge resource of information. I have 2 full pages of notes out of that presentation, because there are so many things that we do not look into during our operations. and now we have certain new information that we need to look into and see how we can incorporate. Thanks, Pragya, for that. Coming to our experience with implementing Let's Doc, I'll briefly tell you about Let's Doc. It's a telemedicine platform which essentially aims at providing doctor consultation services through video, audio, and text, and also in turn help patients manage their condition on the same platform. So we work with various clinics, doctors, e-pharmacies, diagnostic chains, and insurance companies for various use cases for telemedicine and condition management. So we have been working since 5 years, and it is now that we have started looking into interoperability, etc. It is interesting to see that though we were working, we had created our systems totally by ourselves without any reference to any standards. However, there is a lot of overlap that already existed between what the standards want and what we already had created. And hence, incorporating eobjects into the whole system is not a major task for us. I'll come to the challenges basically. So the first challenge that we faced is that when you get introduced to these kind of standards, there are so many terms and there are so many acronyms that like I said, when I was listening to Pragya's presentation, I felt like a layman because I did not know so many things. So getting used to those acronyms, terminologies, etc. takes a lot of time. The team takes a lot of time. So the point I'm trying to make is, if we as providers face, like creators of technology, face so much, take so much time to get used to these terminologies and acronyms, when we take this solution to the service providers, to the users of the system, then how to make it easy in a way that they are able to understand, and not the training cost is not very high when we change the system to a standardized system. So that is what we have been working on. So so the approach that we have always followed is how to minimize how should I put it? How to minimize the amount of information that has to be manually fed into the system. With these standard e-objects, there's a lot of information that needs to be manually filled, and there's a lot of information that can be automatically generated by using the information that we already have. For example, if we know what are the symptoms, what is the diagnosis, and what are the medication that a person takes, then we can map a lot of related information automatically and feed that into the system. So mostly that is what we have been working on as far as implementation of eobjects is concerned. The second thing that we have been working on is, like Pragya also shared, is how to structure the whole information within our database, so that when the output is required, then we are able to create that output without much processing. And in that case, what we have done is, so there are three major as far as encounter nodes are concerned. For example, as far as e-encounter nodes are concerned, there are three major entities. There's one encounter, there's patient, and there's a facility or a service provider. So what we have done is, we have kept everything on the encounter basis. So encounter becomes the key field, and the patient remains as a patient. So patient will have so many other sets of information. So one patient would have, in our system, would have a diagnostic booking, would have reports, would have parameters, would have insurance history, would have medicine order history. So all that is separate. We have kept it separate, and then we have linked that patient ID to the encounter ID, and only the relevant information will be fetched out of the whole information set which is required by the eobjects. So that structuring of the information has been one of the time-consuming activity. Apart from that, the structure that Priyanka and team has shared with us through Excel sheets and presentations, etc., it has helped us dramatically, and we have been able to incorporate most of the e-object parts as far as e-encounter and e-prescription is concerned. We have started working on the e-discharge summary, but since we are a telemedicine company focusing mostly on OPD kind of an environment, so we had not focused on e-discharge as of now. But for the future prospect, we are also looking at it and seeing how we can incorporate that into the system. So that's pretty much it from my side. Is there any question that I can respond to? Hello?
Hello?
Yeah.
Post-lunch session, I think everybody went to sleep. Well, thank you
No,
so
no,
much,
quite,
Conrad.
no, quite the opposite. I think I feel a lot of people are listening very intently,
No,
digesting everything. So
two wonderful sessions, one from Pragya and now from Anurag.
yeah.
I think this is hats off to the entire group.
Yeah, and so one of the major challenges that I just want to share is that we are facing is how to make it so simple for the end user to use it, so that the training cost, because we have around 1,200 doctors on the panel. So if we bring new fields into the system, then it adds a lot to the training cost. And if we add a lot of new terminology, then it adds to the training cost. So that is what we are working on. And we'll definitely keep sharing as to what strategies we used to make sure that it remains simple, and how to minimize that training cost.
I think Pragya has indicated one way. She indicated very clearly that she gave the end users the choice of using SNOMED CT or ICD-9 or ICD-10 for diagnosis, and it doesn't matter what they put in. She'll still be able to generate ICD-10 for a clinical diagnosis perspective. That was one method she used for one area of implementation, simplifying implementation.
Exactly. So what we are trying to do is, so we as in our system, we did not have a standardized input for diagnosis. So what we are doing is that we are keeping it a free text for the doctor and trying to figure out a way to standardize it at our end, or giving them an option while they are typing, giving them a drop down to standardize it.
Yep, exactly.
So, thank you so much, Anurag. Now, I would want to request UniMedNet to share their experience and the work they have done on eObjects.
Yeah, hi. Can you hear me?
Yes, sir, we can.
Yeah. Let me just share my presentation.
Yes, sir.
Okay. Hi, my name is Sanjay Kuddi. I'm representing Universal MedNet here. I'm a delivery manager working with them. And we are basically a team of committed, focused technical professionals. Okay, we are looking towards bringing the transformation that the technology is bringing to the healthcare world. Okay, I am not going to be very much detailed about how the earlier. Hello.
Yes, Sanjay ji.
Yeah. Okay. Okay. So I'm basically going to share our experience with respect to eObjects, what we are doing. So basically, right, as a company, we have 3 products. Okay, one is UniMediLocker, which is basically a digital locker that where a patient can store all their information, including reports, as well as images like DICOM and other stuff. We also have another product called Advanced Teleradiology Platform. We call it as ATP. Okay, this basically allows radiologists to remotely report onto the imaging services that have been provided by the hospital to the patient. Okay, and basically we also kind of work as an aggregator. Okay, where there is shortage of radiologists seen in any hospitals or any other place. We can provide those radiology services. What we can do is we can connect with the hospitals, and we can provide the radiology services as they want it. So these 3 products we already have, and we already already there in the market with these 3 products. Our association started with XSH quite some time back, and like what the earlier Anurag mentioned, that we were not so much focused about compliance and all this kind of compliance in the sense standard compliance. We are compliant with respect to all our data platform and everything, but we were not incorporating the MDDA standards and everything. Okay, so with our collaboration with XSH, we started getting into that, and then the COVID thing stuck, and during our discussions and things like that, okay, there was some discussion with respect to preparing a disease registry for the COVID-19 epidemic. The problem that we have in India is, like, we have COVID patients spread across all over the country, and we do not have a single common database or where all this information is available in a single and importantly structured format. Okay, so we started working with XSH. So before I get into what is a registry, let's talk about what a registry is. So it's basically where the collection of secondary data. So secondary data means the data that is collected by the hospitals about their specific diagnosis, conditions, procedures, etc. And that information is collected and stored in one single place in a standard format. Why such a thing is required? Because that kind of information, when stored for all those thousands of patients that are there, okay, the surveillance teams can try and understand how things are happening. Okay, if there are any treatments are provided, whether those treatments are becoming effective, not effective, whether they are properly implemented, and whether they are giving the required results. All that thing could be done, or all that thing could be collected from that one single registry. Okay, so basically the objective with which we started this registry was to help the surveillance programs, okay, and help the government, and also help the hospitals, all the 3 stakeholders in this whole fight. Okay, so how did the workflow work? Is basically we connect with the surveillance program or the surveillance system that the government has, maybe ICMR, IDSP, or whoever has that program. We have the Setu app and all that thing. Okay, and in the worst case scenario, if they do not have anything, like, because many states have their own applications and systems, so we are ready to even get the data from their Excel sheets. They dump it somewhere. Okay, once this information is is available to us, what we do is we pick up the patient information from it. Okay, we create the medical locker for the patient, and once that medical locker is created, whatever information we have for that patient, we put it into that medical locker. Typically in these kind of scenarios, the patient is referred to an hospital or a lab. So what we do is we connect with that hospital. We could connect with that hospital, and the hospital could connect with us in 2 ways. One is either they can provide us the data using the web services, or they can provide the data using the web form that we provide them. Okay, once we are connected with the hospitals are expected to provide all the information about the patient. So our application can collect it and we can then store it into a standard registry. Now, all this data exchange that would happen with the hospitals or any caregiver entity, okay, will happen using an eObject. So basically what is going to happen is, like, when they want, I'm going to provide, or my application is going to provide them eObjects, and when they are going to give me the data, they are going to give me the data in an eObject format. So an hospital can provide the eObjects either from their HIS, okay, or they can use our web application, or what we can do is, they can dump the information in some place, and then, we can apply our tools to convert the data into eObjects through web services. Okay, we are pushing all this data to our cloud. Once the data reaches our cloud, as I mentioned, the moment we get the very basic information about the patient. So what we do is we create a MediLocker for that patient. And as and when the data keep coming for that patient, the information gets stored on the cloud as well as into the MediLocker of the patient. So patient can view his or her information using a mobile app that we already have. And the data on the cloud storage is in a very standard format. The standard that we are using for everything is, we are using this eObjects Excel sheet as a Bible, and we are complying exactly with that. So we are completely MDDS compliant, and all the information that is stored into our database is all the codes and everything are as per that. How it is going to benefit? So for states and centers, it will help them to estimate the magnitude. It will help them in monitoring. For research organizations, they have all this information that is available, again, in a standard format and not like reports that are there in PDF forms and other stuff. But, they will have all the progression of diseases and everything, or the treatments given, everything into a standard format. We also have, as part of our locker, we also have the X-rays and other CTs and all that are done on these patients. So if the research organizations want it, we can give all that information. We will have all the progression of the disease of any given patient. And of course, the hospitals will also get all the patient information. They will have hassle-free record keeping, because we will be keeping all the records, and we will be sharing it up with the government, of course, with the consent of the patient. For this purpose, we have implemented the eEncounter object, okay, where we are collecting all this information. So the data comes in the form of an eEncounter and goes out in the form of eEncounter. In the database, we are storing it into an RDBMS, where a standard RDBMS normalized data form. Any questions so far? Okay. As I mentioned, we already have a UniMediLocker product, and what we are developing that into further into something what we call it as a PHR application, where an individual can store, in addition to hardcore medical records, the individual can store his or her personal information, daily diets, the glucose readings that the patient do at home. All that thing can be stored into our application. And of course, our application will pull data as and when the patient visits various different hospitals, okay, be it radiology centers or IPD, OPD, whatever it is. We will be accessing that data. Again, eObjects is going to be the standard format that we are using for exchanging information, and will be stored and will be available to the patient whenever they want. Our application also already has got a facility where all this information could be shared with any doctor of the patient's choice, and the patient has got the patient can say that, okay, this information should be available to this doctor only up to certain date, and the doctor can access this patient information, and all the patient's consolidated information can be made available to that doctor, and then doctor can review the patient, can understand the patient's condition, and then consult back to the patient. So we are taking our Unimedilocker towards converting into a PHR, where it will be some kind of a personal health record repository for the patient, and not just for the patient, but patient plus his or her family. And any questions?
This whole COVID, so this is Satish here from Paripal.
Yeah.
This COVID-19 thing that you explained, is that implemented? Is it working along with the government? I mean, you're getting the data?
No, right now we are in the phase of right now the application is in QA. That is, we are testing it. Okay, and we are discussing with the government if they want to use it. How we can work it up with them and take it forward.
Strategy-wise, it's excellent strategy.
Thank you so much, Sanjay ji. Dr. Pankaj, Dr. Balaji.
Wonderful, actually. I was listening through, and Sanjay ji, thanks for the confidence in the group. You even showed your ER diagram. Nobody does that. Hats off. Thank you so much.
Yeah, they have been putting a lot of effort.
This is amazing. Actually, this is going to actually change the face of registries. In fact, now we can go and say that we have something that can become a PHR.
Yes, absolutely.
Yeah. So we will set it up. Kindly share the slide deck with us. For all the 3 presentations. In fact, Android, I guess, didn't use any presentation, but so if you can share it with us, that will be great. So that and also let us know what we can share further, because now that NDHM is getting created, there will be a lot of things that will move at a very fast pace, and PHR definitely is one of them.
So Sanjay ji, it's a pleasure to be connected to UniMedNet.
Yes.
Because of the trust that you have shown in us, and vice versa. It's glad to work with you.
Thank you. Like what Anurag mentioned earlier, we were in the field, but the data standards and that was the part that was missing, that we are now being with XSH through their incubation program, and very closely working with them. And that is what we feel is eobjects is going to be something that will be used as an exchange. I don't know what word to use, but it's going to be the basis for data exchange across all the applications, is what we feel, and that is what we are aiming at, and working with that in mind.
Wonderful.
Thank you. Yeah, thank you so much, Sanjay ji, for this presentation. Now we'll move to a technical approach 2, which is microservices.